So welcome everybody. We're really excited to be doing this talk for the UKSFP conference. We hope you've all enjoyed the sessions you might have been on already. I hope it's gone well. So the session is being recorded. So I guess it's your choice whether to. Sorry, I'm just admitting another person. Whether to have your camera on or not, and decide how much you want to participate or not. So our hope is we're going to present some themes from some of the work we've been involved in, and we're hoping to have some time at the end for a little bit of interaction, questions, people kind of offering reflections, that kind of thing. So we'll see how we go. For questions, we were thinking it might be best if people tap it into the message system, if you can have a go at that. And we've kindly got one of my colleagues, Louise, who's going to monitor that and shout out things near the end if people have got questions or reflections they want to add. And we do hope it will be a little bit interactive towards the end. So and we hope you enjoy hearing about some of our experiences as much as we've enjoyed, on the whole, being involved in them. So without further ado, let me share my screen.
And I think we'll hopefully get round to answering all the questions, though if there's anything that we don't have time for, our emails will be up as well. So yeah, please just contact us individually and we'll be happy to get in touch again.
Right, can everybody see that title screen?
Yes.
Yeah, great. I've just realised I've not really introduced myself or us or anything, so perhaps that's somewhere to start. So I'm Becky. I'm a clinical psychologist, and we've also got several colleagues on the call. So do you guys want to introduce yourselves?
I'm Jo Idden. I'm the principal psychologist as well over in the Southport team.
I'm Rebecca Hunter. I'm a trainee clinical psychologist on placement with the team.
I'm Louise. I'm also a trainee clinical psychologist with the team.
And my name is Mark Guys. I'm the assistant psychologist in the team.
So there's a load of psychologists basically in our service, and we are a clinical health psychology service as well. So the title of our presentation today is the use of solution focused approaches in the NHS in community physical health settings during COVID-19, methods, outcomes and reflections. So yeah, we just wanted to share a bit about some of the work we've kind of been involved in offering solution focused approaches, and how we've kind of had to be a little bit creative, I guess, in our approach during this time. And our solution focused stuff's really helped us with that. So I'm just trying to move the slide on. There we go. Right, this is a picture of sunny Southport. We've got a lovely pier, and the joke is that the sea's always out when you come and visit Southport, so you see lots of the beach, which is not a bad thing, is it? So it's a nice place to live. It's just north of Liverpool, kind of between Liverpool and Preston, for those that are interested. We're in the northwest. I suppose it's a bit bragging, isn't it? But we are solution focused, so we like to show off about our strengths. So we consider ourselves a thriving, innovative service, and some people on the call might recognise the name Dominic Bray. He's our leader. He's the head of our service, and he set the service up with a really strong solution focused ethos, and that's the ethos that we're all working to today. We work mainly with people with long-term physical health conditions, often people where there's no kind of fix or cure, and it's about exploring with people living well with their conditions. And we find using solution-focused approaches is a really good fit. We work really closely with communities and expert patient volunteers. You're going to hear a bit more of that today. And we don't just kind of sometimes psychologists are accused a bit of sitting in their kind of ivory towers, just doing their own little thing, but we make a real kind of effort and think it's really integral to our role to kind of get out there, offer training to various staff teams, work closely with volunteers, all that kind of things. And again, the solution focused model lends itself really nicely to that. Mainly in the past we've done all face-to-face stuff, but obviously more recently, like everybody really, been thrown into this kind of virtual world, so we've been kind of learning on our feet with our patients. We're really proud. We won a Nesta, a national kind of organisation, this Good Help Award, and that's because they liked what we did with co-constructing our work with patients and expert patient partners. And we've got a few publications out there, so if people are interested, we can point you in that direction. And I think there's a few references in these slides as well if people are interested. Okie dokie. Let me move it on. There we go. So the first section of our presentation, Joe's going to talk a bit about group work and expert patient collaboration. So over to you, Joe.
Thanks, Becky. So yeah, so as well as the one-to-one stuff, we offer loads of different sort of group interventions. And I think one of the common themes is that they're all underpinned by the solution-focused approach. So although the content and the topics might be different, we're kind of thinking about the same kind of questions. And so what we do is we generally start from a position of, with the people in the group, thinking with them, what are their best hopes for coming on the course or the group? Ultimately, what is it that they're hoping to get out of their time there? And what would show them that, it's been a good use of their time and it's worth signing up for and worth committing to for that period. Sometimes, it might be like individual conversations. We might get people in pairs doing it, or feedback as a wider group. There are different ways which we might ask these kinds of questions as well, which again isn't really too dissimilar to how we might use these skills in a one-to-one kind of setting. So if we're trying to get an indication of what's important to a person or what their values are, we might ask them, what's the pot of gold at the end of the rainbow that you're hoping to, work towards over the course of the group. And as well as that, something which Becky uses in the page is to think about more future-focused questions and, say things like, suppose we had a time machine or we had the DeLorean from Back to the Future and we could fast forward in time, and suppose that we're sitting sort of 8 weeks from now at the end of the group, or maybe even in a year from now, what things would you hope to be noticing? What would you want to be different? And what would you like to be reflecting on at that moment in time? And it's often quite a nice opening session to just sort of help people get to know each other, relax them into it. And also it gives us loads of rich information about things that we would hope to sort of cover and those best in the course. So yeah, as well as that, we're very curious about not only what people want, but also what they know already, and what they bring along to the group in terms of their existing expertise, their resources, and ideas around how they've made it this far, and what they know about themselves that already helps and already works. And we really kind of notice and celebrate that too. Big part of the group is thinking about those smallest signs of progress and what they would like to be noticing session by session. And sometimes we might even think about using scaling as a way to help them to quantify that and to think about where they are now, and what the next little step would look like if it were to happen. And like Becky said, we work extremely closely with the expert patient volunteers in the team. And these are individuals who at one point we might have worked with individually, so they might have been referred to our service for themselves to learn how to come to terms with and manage some of these physical health conditions. Though over time maybe they have thought that they'd like a role in being able to work with patients who are perhaps newer at the newer end starting point in their journeys. And maybe they think about giving something back, working with us to help them as well, share their expertise, and have a sense of purpose as well in the team. Okay, next slide, please, Becky. So just a little bit about the background, really. I mean, it's a bit of a given, a no-brainer that globally there's more and more people living with long-term health conditions. And just like Becky said, it means that there's more of an emphasis on supporting people to live well despite ongoing symptoms or despite ongoing debilitating health problems. So it's not about finding that fix or that cure. Instead, there's much more of an emphasis on the longer term and how a person can still have a meaningful and well-lived life despite the presence of these difficulties. So that's why, we think solution-focused approach is a really good fit, particularly in this kind of work. We know from literature as well that people with higher levels of well-being do better on a range of outcomes, not just emotional outcomes, but also in terms of their physical functioning. Those people may, if their well-being is sort of higher throughout a process of rehabilitation, or if they're supported to have a higher level of well-being, they might find that they've got a better functioning, or their mobility is sort of better than people who unfortunately maybe don't have the same levels of well-being. So one of our groups is the Living Well programme, and it is a course which is facilitated and delivered by our expert patients who themselves are living with health conditions. So in terms of psychology input, we do the governance around it. We offer them training and kind of do the admin and get people to the groups. But in terms of the delivery, the facilitation, it's the expert patient volunteers who do that. Usually would be face-to-face in a community building. So we use the fire station in Southport. So it's really sort of non-medical, non-clinical, and it's it's actually based upon the expert patient programme as well. We just adapted it to make it a bit more up-to-date and a bit more flexible for our needs and our patients' needs and our locality. And one of the really strong points about this group is that it's got ongoing support as well. So it's not just a short-term intervention, but there's also the follow-ups. And we're currently, hopefully, getting this off the ground to be virtual next month. So we're trying to adapt given the COVID situation. Thanks, Becky. So yeah, just to give you a little bit more information about the Living Well programme. So the content, there are sort of set topics in relation to relaxation and mindfulness-based skills, how to sort of grade exercise in a way that works for individuals, sleep, communication skills. They're really, really important things to cover. And throughout all of it, as I say, is this sort of solution-focused framework and ethos about noticing person-centred goals and thinking about those little signs of progress towards them. Using this kind of menu-based approach as well. And even the content is kind of decided by the attendees. They'll identify what would be most useful to spend time on in each session. They get given a folder with all the information in, so relaxation CDs, lots of signposting. And again, these are all sort of activities and places that we signpost to that are local to these individuals for that sustainability and that longer term input. As I've mentioned, we work to train the expert patient tutors, the volunteers, so that they feel supported. And as well as that, we think about our evaluation processes and make sure that, we're collecting data and outcomes as well, so we can prove that, or evidence at least, that these groups do make a difference. Okay, Becky. The slide. Thank you. Cheers. So once people have been on the Living Well programme, that's usually for around sort of up to about 3 sessions, and that's where they go and sort of develop their skills, like fine-tune what they know already, think about goals. There's opportunity to then come to the longer term follow-on sessions, which what we call Living Well course. And here's a little screenshot from the most recent session that we had. And it was somebody's birthday, and they've got a lot from being in a group with people who seem to get it and know what it's like to live with, in this case, chronic heart disease that really impacts his functioning and his mobility and energy levels. And one of his best hopes was to just be able to share a slice of cake with everybody and to feel connected despite COVID. So it's the kind of what comes out of these sessions as well. And when things perhaps aren't going well for an individual, or they've had a tough week, the tutors may ask questions around, how are you hanging on in there, and how are you managing to keep on going despite, having a flare up in the pain or whatever it might be. And again, there's that sense of continuation where they're looking for little signs of things feeling a bit more on track from session to session. Thanks, Becky. Oh,
is it my turn? So I'm just aware of the time, so we'll move it on quite quickly because we've got so many things to show off about. So I work a lot into the community pain service, and we do a lot with a peer support group which is called Pain Clinic Plus, which again is delivered by expert patients, and they had to transition over to kind of virtual delivery. And I think when you work in the NHS you get a lot of kind of I suppose maybe the word is red tape, isn't it? Sometimes it's hard to have just enough governance, which you need, but also make things possible as well. So kind of if you take your solution focused thinking to that, that's really helped me think about, okay, what was good about the face-to-face thing? What do we want to keep hold of? What would we love a virtual thing to look like? And that kind of helps us kind of think through and co-construct and make it happen really as well. So yeah, there was a lot of ins and outs that happened. We had to find the right platform that the trust was happy with. It was a whole learning process, but I think probably my main message is for those who are maybe starting to think about these things. I would guess probably a lot of services are thinking about them now because we're well into this kind of COVID thing. But it is possible and it's worthwhile, and we introduced various kind of guidelines and stuff for people that are thinking of signing up to try and make it like a safe space and stuff. So if people ever want to kind of know a bit more about that, you can always email us and we're happy to share some of our materials. Yeah, and similarly we run just started actually, it's week 2 now of a 9-week program. Pain management program is kind of like the treatment that often gets offered when there doesn't appear to be a medical cure or fix for pain. Often people are offered to go on these kind of group therapeutic programs, and the one we're running in Ainsdale, again we kind of gear it around solution focused principles. So we cover some of the more traditional perhaps topics of pain management, but we do it in such a way that we place the patient as the expert. So right from the assessment process, it's all about what the person's best hopes are, what their strengths are, rather than kind of screening people in and out based on criteria necessarily. It's more about, well, what are their hopes, and is that a good fit for a therapeutic program like this? That's our starting point, and that's the thread that runs all the way through it. So again, if people want to know more, we've done a few papers. So I think that's probably the most recent one we've done on our pain management program in the British Journal of Pain, and it kind of showcases our outcomes and stuff. Yeah, so it's been a bit of a challenge to try and move it virtually because there's been a lot of aspects to think about, because we have physiotherapy group exercise sessions on the program normally. So we've all had to kind of think outside of our boxes and push our comfort zones and stuff to try and make this possible. But again, with a bit of thought about, well, what is it that we value about running P&P? What do patients tell us they value? And we've tried to kind of keep that ethos when moving it online as well. Yeah, so if people want to know more, feel free to ask at the end, or you've got our emails and stuff there. Okay. This is just a flavour of some of the ways we're kind of bringing solution-focused ideas into the assessment process. And all of our assessment is based around best hopes and how people have already managed to do what they do and that kind of thing, to find out if it's a good fit. Right.
Okay, just to be mindful of time. So yeah, as well as Living Well group, as well as the management side of things, there's also the monthly mindful living groups. And again, recently this has gone virtual. We had the first session a couple of weeks ago, and this is a space where people can get together and really sort of share ideas around mindful living, how they're able to use these ideas on a day-to-day basis in their own lives, and practice sort of mindfulness-based exercises together. So it's facilitated by psychological therapist Ruth Dark in our department, and also with lots of facilitation and input from an expert patient volunteer, Mark, who you'll hear about later as well. And again, it's that same SF flavour throughout, so thinking about what have you been pleased to notice since we last met. And sometimes examples might be, I've been pleased to notice that I've been able to pay particular attention to things that I wouldn't have maybe noticed before, and I've felt more grounded, and you know, it might be like the flowers on the trees, that kind of things, or you know, on the leaves, and that's made a difference to people. And there's a real emphasis again on getting through what their strengths are, thinking about their coping, and not just their own internal strengths and characteristics that help, but also what's happening externally and what support systems have they got that help them. One thing that I think is really important is to make sure that the measures and the questionnaires that we administer as part of our group work are as well aligned as possible as they can be to kind of our ethos. You know, it's an important thing to be able to capture change, because not only is it good for us to know what difference it makes, but we need to be thinking about, you know, for commissioning, proving that these things make a difference and are worth funding again next time. And there's lots more evidence coming out in the literature about how, you know, psychological distress and psychological well-being perhaps aren't the, you know, opposite ends of the same continuum, but maybe they're actually separate processes that can run in parallel. So it doesn't always make sense to look for a reduction in symptoms of depression or anxiety. But instead, you know, rather than thinking about getting to the -10, like fully distressed, to 0, like neutral, it's more useful to think about growth and well-being. So there's some ideas there for that. Again, if anyone's interested in what questionnaires we use, then drop me an email. I'll be happy to share that. So here's a video of myself and Mark, our expert patient volunteer.
Brilliant to have a chat with us today.
Very welcome, Joe. Great to see you.
Thank you. So I was wondering, Mark, could you tell us a little bit about your role as an expert patient volunteer, and maybe a little bit about how you came into it? That'd be great.
Yeah, sure. So I'm a community and wellbeing volunteer, primarily involved with the mindful living group that your lovely colleague Ruth Dark runs, and I've been doing that now for a couple of years. And it's a great opportunity where we can come together as a group once a month, and we do some mindful practices, but also incorporating the solution focus as well. So things like, what have you been pleased to notice? And it's a great time for us all just to get together and to share our experiences of mindful living.
Mm-hmm. And had it been something that you'd come across before, or was it all kind of new to you when you were a volunteer, like the solution focused things?
Well, the solution focus certainly wasn't, just because I'd had the opportunity to meet with one of your colleagues, Dr. Dominic Bray, and Dr. Bray very kindly spent some time with me in sessions as a client, going through some solution focused stuff with me for my long-term health condition, and that was really, really helpful. And following on from that, Dr. Bray suggested that I met with Ruth Dark, who, as I just mentioned, runs the Mindful Living Group, and I spent quite a lot of time with Ruth, going through some mindfulness and integrating that with some solution focus techniques as well, which really helped accelerate my the change that I started to experience. Mm-hmm. And in particular, it was those sessions with Ruth, and really digging into some of the mindfulness stuff that really resonated with me. And I see a lot of connections between solution focus, brief therapy, and mindfulness. The whole noticing thing, I think, is very powerful.
Yeah, so you've got some experience of not only asking these kinds of questions in your role, though also being on the receiving end of them as well.
Yes, absolutely. And I think one of the most powerful things for me really was the fact that in many senses it's allowed me to become my own therapist in a sense, in so much that when I'm struggling, I can use those resources that I've been generously given by your team to enable me to continue to find change in my life, to continue to move forward and to look for those solutions. And it's made such a massive difference.
Wow.
Huge difference. And I've not only experienced that myself, but my family's also experienced that difference in me.
Wow. And sorry to put you on the spot even more though, can you recall any particular sort of point in those conversations with Dominic, or question or area that you were thinking about that seemed to be the difference that made the difference ultimately?
Yeah, absolutely. I think one of the things that used to frustrate me a little bit actually, because I want to go into each session and talk about the problem.
Yeah.
And Dr. Bray would really focus on the solution and what's changed, what's been different. And even though I had this list of stuff that initially I really felt I needed to go through, once we actually got into the change that was actually happening, and once I started to really notice that's the thing that made the change. I started to become much more aware that change was in fact happening. And even though initially it may seem to have been very slow, over a period of time it accelerated. And I became more and more aware of the change that was happening, and it got to the point where rather than wanting to go in and talk about the problem, I was really excited to meet with Dominic and to go through the changes with him that I'd been experiencing since our last session.
Wow.
Right, so I'll just move us back to our presentation. New show.
Nice little cringy moment to stop it on there with me gazing into space.
Sorry, Joe. Okay, just gonna flick through to where we're up to with our slides. Yeah, okay, so I think it's now over to, if I can get my mouse working, Rebecca and Louise. Yeah, over to you guys.
Okay, thanks. So we're going to do a few slides on a project that Louise and I have been working on, which we've called Photosynthesis for Teams, a Tree of Resilience. And as we said at the start, we're trainee clinical psychologists on placement in the service. Yeah.
So the background for this project came from the district nurses in our NHS trust, who came up with something that they called a worry tree to help leave worries at work during COVID-19. So they had a picture of a tree and they would write down their kind of worries or issues as leaves and stick them on to kind of have a bit of time to sort of space to think about them and to kind of leave the worries at work. And we heard that they were kind of having conversations about this as well around teams too. And this reminded us of the kind of tree of life concept, and it's a concept that's often used in narrative therapy, so it's the visual of a tree. And we thought we'd expand kind of the worry tree to this metaphor and use a solution-focused approach to include some of the values, skills, and some of the positives that might come from difficult times. And we also incorporated some solution-focused questions to help initiate and sort of guide conversations within teams as well. So what started as a project elsewhere in the trust, we kind of took a bit of a solution-focused spin on it.
Next slide, please, Becky.
Is this where I show the tree?
Yeah.
Okay, bear with me.
So we're just going to show you the concept and talk you through an example that we completed as a team as well.
Is that showing now?
Yeah, yeah, that's fine. So this is what it looks like. So we'll talk you through it. So the roots and, represent the values and commitments of the team. So what is it that's important to this team? What values underpin their work? Then the trunk we've got as the skills and resources that are within the team. So skills and resources of individual team members, and I guess that can also be kind of internal and external resources that they've got. Then, as Louise said, we've got the leaves, which were the original kind of worries, so individual team member worries, and see they'll be quite fluid and change. And then this is when the kind of sciencey bit comes in, which I can't take credit for. Dominic Bray helped me think about this. But so in the process of photosynthesis, when the leaves kind of die off, the sugars that they produce are what kind of helps the fruits to grow, the flowers to grow, and promote growth within the tree. So we thought that adding that kind of element would kind of incorporate the positives that can come from the concerns. And I suppose the leaves are kind of like the seasons, they'll come and go, but the trunk and the roots are kind of stable and keep the team grounded. So we completed this as a team in one of our team meetings, and what we came up with for the clinical psychology team was that some of the roots, so the values and commitments, were around compassion, so showing compassion to each other and to the people that we work with, being useful, particularly in kind of COVID times and having lots of work, and being curious in the work that we do. Some of the ideas around the skills and the resources were around working well as a team, our listening skills, being on the lookout for strengths and resources, compassion again, and empathy. Some of the concerns that the team had were around kind of being isolated, so we're all working remotely and we have been since April, so that kind of disconnection from the team, COVID-19 and the kind of worries about contracting the virus, lots of issues around kind of uncertainty and what the future holds. And then so through the process of photosynthesis, the fruits that we thought that could come from this were around being more compassionate in the work that we do in the future, having better working relationships and kind of finding different ways to connect, so through Zoom and kind of other ways. And then what else have we got? Oh yeah, so adopting kind of better habits for well-being, so kind of thinking about what we need to do for ourselves to kind of maintain our well-being when we're at work. That was one thing that came out. And then Louise is going to talk us through the questions on the side.
Yeah, so we've also got some solution-focused questions to help guide. So either self-reflection of what people might like to think about as they kind of fill this out, or day-to-day for themselves, or how some of these questions might help facilitate discussion within teams. So within that, we've got some questions about kind of self and resources about yourself, increments about what a good day might look like, what you've been pleased to notice, so getting that noticing in there, and also thinking about the system and who can be around for support, especially in these times where people might be feeling quite isolated, either in work or outside work as well, and that these people might not necessarily need to be present, but they might be a virtual community, or it might be a pet. So thinking about some of those strengths and resilience that people have within themselves, others, and then thinking about past challenges that people might have had and how they've got through those difficult times before.
And I think a reflection kind of from me in terms of kind of when we were doing this, I was pleased to notice that it felt like everyone in the team kind of had something to contribute, and it kind of captured all the different perspectives of what that team is like to be in, really. Next slide, please, Becky. And again. Thank you. So what is next for the Tree of Resilience? So we've shared it in the locality quite recently, so we're still waiting on feedback as to how it's going and how it's kind of being used. The original team who created the worry tree are considering using the new version, or the updated version, I should say. And then our manager, Dominic Bray, has been using it in return to work training with managers alongside the HR department and organisational development. So for managers to kind of use it when staff are coming back in off a period of sickness. So again, we're waiting to hear how that's going. So that is the tree.
Great, thanks guys. Love the visual of the tree, it's really cool. Okay, so the next little whistle stop tour we've got for you is literally a fast run through of some training we did with an organisation called Living Well Sefton in our area. So the Living Well Sefton project is all about kind of communities, so people that work for that project are like social prescribers. You might have heard of it. It's a relatively new role, and it's, as I understand it, it's kind of like about taking the load off some GPs and trying to help people almost like through social prescriptions to live better with long-term health conditions. So it kind of links quite nicely to our role as clinical health psychologists as well. And they do other sorts of things like some people have roles in community centres, running befriending groups, all sorts of kind of roles involved in the Living Well Sefton project. And I've probably not articulated that very well and done them enough credit, but they're an amazing organisation. Well, before COVID actually, they'd heard a bit about solution focused ideas and wanted to do some training. So we'd already done a little bit of training with their staff, and then COVID hit. And all these people that were kind of fairly new in role, and their role was to help people get out and about more, were suddenly thrust into a whole different role, which was working over the phone with people they'd never met, who were angry and frustrated and upset about being trapped inside, as you know, lots of us have been. So we thought, okay, what can we offer, given we can't run the full-on training? So we kind of had a think, and we thought, well, we'll offer them some bite-sized sessions, and we framed it as strengths-based conversations. So it was basically taster sessions for these members of staff to look at ways of facilitating conversations, build constructive listening skills, and looking at kind of growing coping skills in these people. They were basically quite often like cold calling, essentially. So we had 3 cohorts of staff, so we had 22 in total, but we broke it down into 3 groups, and we did 1 training session per group for 2 hours. So it was kind of short and sweet, really, because often when we run solution focused skills training, we take 2 days, and then we offered follow-up sessions as well to the staff. Ooh, I can hear a weird crackle. Is everybody on mute? So we before we kind of delivered the training, obviously we were curious about what their best hopes were, and we gathered that by email at the time, as well as talking to their boss. And here's a flavour of their best hopes. They wanted to basically feel better in their roles and feel like they were being more useful to their service users. And we asked, what difference do you hope the training would make to your work and the service users? And that gives a flavour of the kind of things they were talking about. Okay. How did we do it? So like I said, we had 2-hour training session, focused really on strengths-based conversations, using solution-focused kind of questions and concepts. We had a big focus on listening in our training, because what we find is if you don't give people a good enough listening to, sometimes people don't engage as well with solution focused kind of questions. So we trained our workers in listening skills, listening with a constructive ear, donut listening, so listening for resources, offering summaries, and then a flavour of some strengths-based questions as well. So that's just a flavour of what we went through with the staff members, and they got like a handout as well with it all on, because I often find that people ask for that, and actually that was one of their best hopes, to have like a little roadmap, so that when they were on the phone they could kind of like refer to it whilst they were kind of learning the skills, really. And then Louise is going to say a little bit briefly about the outcomes.
Thanks, Becky. So we designed an in-house questionnaire in order to cover the aims of the session, which was then delivered online. So the 3 main things that we kind of wanted to hit with the training was the listening skills, summarising skills, and being able to elicit individuals' current coping skills and strengths. So we asked participants to rate on a scale from 0 to not at all confident to 10 extremely confident. And there was also a follow-up question as to what made you choose this response and another. So I guess that's kind of picking up on some of those increments of so why it's a 5 and not a 4, or why it might not be a 6. And then we looked at these before training and after training as well. Oh, it's not coming up for me yet.
I think there's like a delay.
That's okay. So we had 18 responses pre-training and 11 after, and we can't like fully match them up, but so we've just done some of the averages and the ranges. So it was positive to see that even before training that people felt that they had skills within these areas and felt that it's something they could build on. And then it was really positive to see that after the training they then felt more confident in using these skills. So it might not be that they didn't feel that they had them, but I guess it's increasing that confidence to use them as well. So that was really positive. Let's pop it to the next slide. People found that how useful a session had been from 0, no use whatsoever, to 10, exceptionally useful. They rated it at an 8.6 average. And we also asked the question, would you recommend this presentation to colleagues? If so, how would you sell it to them? And we'd had some responses about people already telling other people about it, and people kind of picking up on what the message that we were trying to put across was. So encouraging people to consider their own strengths and how useful it was for, especially at the moment, for people using the telephone to communicate with others. And we also asked what would even better look for next time to help shape the follow-up sessions as well. So in the follow-up sessions, we kind of condensed the 3 areas down to 1 question because we know that time is of the essence for many, many people. So how confident do you feel in having collaborative, strength-based conversations with distressed individuals? Again, using that same scale, why this response and another, and also asked how useful the session had been as well. So we've got some results from that. So most people felt quite confident in having these conversations. Had a little dip in the follow-up 2, but follow-up 3 people had gone up to sort of 8.8, which is pretty confident, and people have found the sessions useful mainly. And I guess kind of with people getting more and more confident, people might not have found the sessions as useful. There was quite a wide range of skills already in the team, and some people felt more confident using the phone than the other. So I think the range in these scores kind of highlights the different levels that people felt that they were at.
Also, I think around follow-up 2, it was that time when everybody thought they were going to get like let out of lockdown, and then they weren't, and then there was all these mixed messages, and the staff were having to kind of handle this extra level of distress as well. So that's quite interesting as well.
And then from the follow-up sessions, we kind of instilled together kind of the key themes that had come out. So there was a sense of instilling hope. So asking these strength-based questions rather than what's wrong had kind of really produced kind of shift in the conversations and the conversations that people were having, and people were beginning to talk more about coping and noticing things when things were going right. And people also felt that once they put the phone down, they didn't feel as kind of heavy, or that they'd just taken on other people's problems, because it felt like they were having a bit more of a skills-based and a strengths-based conversation, and therefore it wasn't as heavy for them, and therefore it was better for their well-being as well. And we also got a sense that, just given that people are kind of working in quite isolated ways, the groups really enjoyed meeting up with each other virtually and having a space to kind of get together and share good practice. And that's something that we thought might be quite useful for them to carry on to do, and having more kind of peer supervision as well.
Great. Can we whistle through this, Louise?
Yeah. So we, so as well as the people that are social prescribers, they also had an influx of people wanting to be volunteers. So we did the training session with some volunteers as well, people from a wide range of backgrounds. So we trained 7 people, but unfortunately we've had the follow-up today and we had 3 people, but people starting to be kind of unfurloughed and going back to work. However, kind of from the responses that we got, if you look at the next ones, so people, given that people might be from different backgrounds, to begin with they were feeling a bit less confident, but then felt a lot more confident after the session. And then I think we just got one more on how useful people had found it. So we got a 9.3 on how people found it, and the feedback that we've got is that people are using it on the phone, but also with their colleagues. So it's not just a client to staff kind of thing, it permeates within staff and within teams as well.
Thank you, Louise. Right, over to Mark.
Thanks, everyone. So hi, my name's Mark. I'm just here to talk about changing conversations in risk management. So I suppose before we start, what I would say is, there is going to be a few themes of threat systems and suicide and maybe self-injury. So, if that does elicit any, uncomfortable feelings from anyone, please just look after yourself and do what you normally do, to look after yourself. Just thought I'd mention that. So we've called this new model risk. So looking at resources, looking at increments, looking at how we can share that risk and also the knowledge as well. So this came about really from Friday morning in July. I think I'd been with the team, around 6 or 7 months. And a patient arrived in the waiting room who came on the wrong day. So it was a Friday the 23rd of July, and his appointment was meant to be the 23rd, of June, and his appointment was meant to be July. Came on the wrong day. These things happen. And I suppose it's one of those moments where a situation enters the room that you were not expecting. And largely at the time, although I've been prepared in risk management, working in a CBT model, working in a solution-focused way, it was not something I'd done, particularly up to that point. So it was a sort of a moment where you take a deep breath and then do what we always do in our service, which is, stick to the model. And I suppose this is what I found from giving it a go, and also being able to ask, emphatic, validating, and normalising questions to someone who was presenting with significant risk. Next slide, please, Becky. So a few things to remember, and I suppose, working in a solution-focused way, Keir Harding, who's an occupational therapist, said about the curiosity about, why suicidal people are still alive is a central part of the work within mental health. And that aligns itself quite nicely to a solution-focused approach. And thinking about it for us as well, the people that we see every day, have been without us, for a while. So again, let's be curious as to how they've done that. Thank you, Becky. So why is this needed? Healthcare professionals on a wide range and scale are either massively confident in assessing and reducing risk and helping and being, helpful to people. Others, on the other hand, are not. And I suppose that comes with training, comes with experience. And the reason why I thought about this in a bit more detail and delivered it in such a way is that risk management is all of our business. It's something that it doesn't matter if you are a cleaner in a hospital, on the reception of a GP, or the GP. Risk management is, is all of our business. I think an important thing to mention as well is a lot of the evidence has said that a lot of people who unfortunately do go on to end their lives have been in contact with a healthcare professional at some point, at least within the last month. So it's really important. And what I'm always curious about was looking back at my time working on hospital wards, is that you would have cleaners who would have this magic ability to learn all the families' names, to ask them how they were, and to be really good listeners as well. So as this lovely cleaner I used to work with would be cleaning the room and tidying about, she had these wonderful listening skills. And a lot of patients would share with her how difficult their lives were at that time, and then she would be able to feed back and say, what, the chap in room number 6, you might just need someone to go in. Really special abilities that people have got, and it comes down to something we mention in our team, the ability to give people a good listening to can make all the difference here. So what do good words and an approach look like? So this is what I found in that conversation. So initially, again, making sure that we're able to listen to people is a massively important thing. We can have a little bit, I think Becky mentioned before, we can have a little bit of a misstep in conversations. If we go into too much of, well, how have you got through that? Or how are you still here? It can come across as a little bit, maybe not compassionate as we would expect. So again, we need to ask these questions at the right time. You know, we're leading that dance. We want to make sure we are putting a step in the right direction at the right time. So once, and again I say it's sort of enough listening, it's about dipping your toe, and if problem talk returns, it's about continuing to listen. But, you know, I suppose sensitively asking, you know, how have you managed to get this far? I see you've come to the appointment today, and even though it's the wrong day, you've still managed to get here. And this chap is a person who took, you know, 2 buses to get to my appointment, which is an enormous commitment for someone who's struggling to come to a health appointment. So again, a little bit curious about that, and building resources as well. So I've listed a few questions there. The one I think I asked him was, you know, yeah, how have you got this far? And as well, I think he mentioned as well about talking to his son, and, you know, how did you know how to do that? How did you know that was helpful? Because it sounded like when he was being around with people, that was an enormous help for him. And there's a few other questions there to elicit resources. Again, increments or scaling questions, you know, as we would call them, again, have to be personalised. Again, how confident are you that you can keep yourself safe? Again, we can only really ask that question, I believe, if someone has said that that's their best hope for the future. So they need to be really personalised. What I heard with this chap was, I want to get back to my old self. So it was nice to check out actually where he is, what his old self would look like, and build a really strong image of what that would look like. And then checking out across that scale where he was. He said he was a 1, and he was a 1 that day because he noticed that he'd had a chat with his son about the football the evening previously. And what was going to be noticed as a 2 would be if he did that walk. He lived near a sort of a pond area, and he was quite enthusiastic about looking at the wildlife. And he'd be noticing, actually really focusing on the wildlife and focusing on colour, and that's what I'd say to him. He was a 2. Again, what scaling would look like needs to be personal, and it really does fit quite nicely with managing risk and where people want to get as well. Next slide, please, Ben. I've got like 3 minutes left, I think, so I'll keep going.
Sorry,
I'll keep going. So yeah, sharing as well. I think being able to share information sensitively. Again, we don't want to be those healthcare practitioners who say, right, we're going to tell your GP and we're going to tell the people you live with and we're going to tell everyone. We need to make sure that who we're telling, we've got a little bit of permission to do that. You know, we ask to be the expert in these. We ask, you know, for our expertise to be invited into the room in these conversations, and if we're going to invite anyone else in, we want to make sure these are the right people and we've got permission to do that as well. And if we go to the next slide as well, Becky, where time's gone. You know, knowledge as well. So again, a lot of the time in our service, what we do, well, I say every time when it is right, a solution-focused letter back to anyone that we speak to. This is a really good way of repeating back to that person all the knowledge that they've got and sharing and amplifying that. And again, we can ask permission to share that with other professionals. This might be someone who lives their housing officer, it might be probation, it might be GP, it could be any professional that is with that patient that we support, and that might be helpful as well. Next slide, please, Becky. So again, just to finish off, really, this is what I was thinking, was when I did this presentation, we think about risk management, we think about conversations that we have, and they really don't stand alone, actually, unfortunately, in the world. And I don't think conversations are, yeah, they are helpful and they can be a response to it. But if you go to the next slide, Becky, there's a lot more, you know, moving parts to this situation. If we were looking at Paul Gilbert's evolutionary model, if we think about soothing responses and threat responses, particularly in COVID, there's going to be a lot more threat responses that we're going to be hearing, and we have heard as well as a team. If you think about shielding letters about people not going out to initiate their soothing responses, seeing grandkids or exercising or going to work or even going to the park, and even that letter arriving on their doorstep, we've got to think about these threat responses. And in the context as well, suicide, unfortunately, the last 3 years is on the rise as well. We think about human rights, we think about racism, and we think about waiting lists, particularly for cancer care there as well, in the social context of austerity. And any community services that were once helpful to initiate soothing responses are now not available. So these systems have all been around these threat systems, but it appears, I think, last sort of 2 or 3 years particularly, that these are more present than ever. And again, in our solution-focused, next slide please, Becky, you know, in our solution-focused conversations, we need to think about these wider systems. The number 15 and numbers have appeared in my presentation because in a global solution-focused conference, unfortunately, in the time that I've only been speaking, which is about 9 minutes, 15 people around the world have ended their lives. This is very important, and this is why we really do need to have good conversations with people. But if we look ahead at our next slide, it's something that invite you to reflect on is, you know, if we were to talk again in a year, what would you have been pleased to notice about these systems? You know, in these systems, what was or is working already? And what qualities do we have, solution-focused practitioners, in our approach that tell us we can be part of a change process? So they're sort of reflective questions that, you know, we can ask in the current world. And yeah, thank you. Oh yes, and just a little quote there as well. You know, words can make a difference, either strengthening a hope, or equally as well, you know, bad words, you know, can increase people's wish to die. So our words are important. Our solution-focused stuff does make a difference. So, you know, my message to everyone is keep it there and keep having good conversations.
Thanks, Mark. And I guess the ideal is to co-construct, isn't it, who you share that information with if you're working with someone in distress. But sometimes we have to share the information even if they don't want us to, because we in the NHS, well, certainly in our roles, we've got a duty of care, but I guess everybody's role is going to be slightly different. But solution focused allows us to co-construct that most of the time, I would say.
Absolutely.
Yeah, grand. Right, I'm really sorry, everybody. We've filled up the time talking at you. I'm really sorry, but we're available to hang on to the call if people want to stay and ask us questions, or if you want to email us, we'd be really happy to respond that way as well. So I don't know, over to you guys. Any questions? If you need to go, please just go, because I'm aware time has got away from us. Any questions, reflections? Is there anything in the messages? Do people just want to unmute? Because I don't think there's loads in messages, is there, Louise?
There is just lots of compliments, which is very nice to hear.
Oh, that's really nice. That's really lovely. Yeah, any questions, thoughts? Are you doing similar stuff to us? Have you got any ideas for us, you know?
I've got a question.
Yeah.
My question is about the training of the expert volunteers. What kind of training do they get? Say, for example, in the Living Well program, how much training do they get on sort of constructive listening or solution-focused questioning? What does that training look like?
I think because often these individuals themselves have things like pain, long-term conditions, we try and do quite frequent, but maybe like maximum like morning or afternoon sessions. So keep it maybe to like 3 hours at a time, but then try and do it quite regularly. And again, kind of giving them the written stuff to back it up as well, and lots of opportunity to practice these kinds of questions and experience asking them, being on the receiving end of them in role plays. That seems to be really helpful. And like the risk management stuff that Mark was talking about, and making sure they feel supported from our own like risk management procedures within the trust. And not only that, kind of asking those kinds of questions, so it's like the solution focused safety as well. And we ask them, you know, what do you want to know more about? We create bespoke things for our patients and volunteers as well.
And sometimes the funny thing is you find people are naturals at it because they've kind of been through a process themselves, often a learning process of living better with their condition, and quite often they've worked with one of us. Not all of them will have done, but quite often they've kind of like come through the service themselves. So it's like you find that some of these ways of thinking start to become ingrained because that's what's helped them, and then they start to use them to help others. So yes, we do some training, but we try and kind of bring out that naturalness as well, if you like.
Yeah, because that's the value added of them if you like, leading rather than the expert leading in a way.
Yeah. And definitely, I mean, I think the expert patient role by nature is different to a clinician role, because they are coming at it from a position of lived experience, aren't they? So we find that sometimes that they tend to use like a combination of solution focused framework, but then if the person wants to know more about, well, how is it for you and what is your story and what works for you, they can be an advisor in that respect. But we try and kind of work with them at looking at it in terms of being like an expert by invitation, if you like. So because sometimes I don't know, I guess in the past perhaps I've worked in services and kind of dipped my toe into support groups, and you find there's one person just desperate to tell everybody everything about their experience, and that's not always great for the recipient, is it? So it's kind of like we use their best bits, and then the solution focused helps them to kind of frame and listen better and all those kind of things. So we find it goes really like hand in hand kind of thing.
Yeah, that's great. Thank you.
Any other questions or reflections?
Can I just say hello to Norma? I think we spoke last year at a conference.
We did, yes, at conference.
All right.
And I'm very interested in all of your work, because the service that I volunteer with, we have had to move online. And I'm a counsellor, so I'm working with individuals. But very fortunately, just in this last week, another organisation that I'm with, we're taking over a school which is being moved into a new purpose-built building. And I've got a fancy wellbeing coordinator title, and I would be very interested in setting up one of your Living Well groups, because part of the area that we will cover is quite poor and deprived, and individually I can see or speak to maybe 8-10 people a week, but with a group and expert people to talk with groups, it would make such a difference.
What we did was to sort of adapt what we thought the best bits of the expert patient programme was, and
Yes.
come up with a little bit of a tutor manual, because you know it can be quite daunting if you're a volunteer running these kinds of groups initially. So we had quite a graded program where people could build the confidence and chip in, and then gradually build up their like facilitation skills over time.
Yes.
You might come along to a group as a participant initially, kind of feel what it's like to be, you know, taking in all these topics, this information, and then, you know, if they want to volunteer, then come along, maybe then doing a bit more of like a meeting and greeting role, befriending within the group sessions. And yeah, as I say, we give them like a bit of a manual, but it's very flexible. You know, they go with the preferences of the group, but there's a bit of a structure for each session that they can follow should they wish to. So yeah, by all means, if anyone's interested in hearing about that, I'll be happy to share that.
I always, when I first came to some of this stuff, I was like, well, how do I be solution focused and work on topics? Like, because that's two different principles there, isn't it? Like teaching topics and being solution focused. But I found that you can marry the two. So you're not being purely solution focused, but you can take a solution focused approach to a group delivery, and
Yes.
it helps to amplify your participants' voices, preferences. If you look at all that from the start and then you marry that up with, here's some stuff you might be interested in that seems helpful to other people, it seems to work pretty well for lots of people. So I think there's often great value in purist solution focused groups, but for us working in some health settings where there's some kind of there's an expectation that you deliver some expert stuff as well, you can still take a solution focused approach to that, I think.
Yes.
And I mean, we're really passionate about working with our expert patients. So on the pain management program we've just been running, we had we had we've always had our expert patients in at the start in our first kind of session, but we put even more emphasis on it recently in our virtual session, and it just went so well because they modelled stuff like hope and change and all those things that as a clinician, yeah, you can ask all the questions, can't you, but you know, people just relate to other people with lived experience of the same thing they're going through. So I would say it's so powerful and valuable.
And now that you're doing this these virtual sessions, are you going to be offering it out of area, or is it just going to be Sefton?
That's a good question, isn't it? Because the world's your oyster, isn't it now, virtually? I think it's I don't know, it is a good question. It's something I was asked by, so we work for this massive organisation called Lancashire Care. So even though we're not in Lancashire, we're in Merseyside, we work for Lancashire Care. It's another whole story. But they were saying in their Lancashire Care Recovery College, can we offer sessions to people who live in Chorley and stuff? There's a bit of NHS red tape. So if you're thinking of chronic pain, they have to kind of be assessed by the service and all that. So we wouldn't maybe offer it to those. But then if you think about a more generic program like a Living Well program, possibly. However, we also find that there's locality specific value. So people make connections with people in their local area, and then they'll go out in normal times for like a coffee, or like they'll join a gym together, or so I would say that's a really helpful aspect to what we do and why it's helpful to do it locally as well.
Yes,
I agree. I think, Becky, I think a lot of the signposting we do are to like sustainable, ongoing activities within their immediate local area, as part of their ongoing self-management and connecting with other people. So, but yeah, I think there's definitely, if it's about sort of sharing the topics and the knowledge, absolutely. But then it's how do we sort of embed that within their local communities, which could be a bit of a challenge if we're sort of spread out. Yeah.
Because the charity I'm with, we're now offering counselling Scotland-wide.
Wow, brilliant.
Doesn't matter now that we're online.
That's brilliant.
And there's online.
It's an amazing change, because in the middle of March, it was a donation-based service, and we could only accept cash. We didn't even have a machine. A card machine.
Wow.
And then suddenly we're online, and we have this huge technical back room, and we're saying, well, if you're from the Highlands or the Islands, yes, we'll accept you.
And I think for those kinds of online groups, there's no reason why you couldn't then signpost to like Zoom choirs or Zoom crochet clubs, or have that based approach, but again on virtually.
It's as wide as your imagination can be.
Yeah. Any other questions or reflections, or if we just, I feel like we've talked loads and not listened enough maybe, but no. There's a little message about email addresses, isn't there? I think, Norma, you've asked me.
Yes, could you display them?
Yeah.
I've broken my shoulder and it's very difficult to write.
Oh right, yeah. Can anybody remember what our Southport Psychology email address is?
I can get it now.
It was on your first slide.
Is it on the first slide?
Very first slide at the very start.
Maybe if I try and share screen again.
I remember seeing it and thinking, oh, that's good to know, but I didn't write it down.
Did it fly by, maybe? Here we are.
Yes.
Let's.
I think it was support at psychological services or something.
I always get mixed up where the dot is. Right, it's capital S for Southport, dot, clinical psychology, capital C, capital P, southport.clinicalpsychology@lancashire.nhs.uk. So that's our global email, and then the secretary can direct it to whoever's best to answer the query, I think. Yeah.
Thanks, Louise. You put it in.
Got that.
Great.
Yeah. Any more questions or thoughts? Or it's been lovely that you've stayed to listen. Thank you for that. You always wonder who's going to come on these things, don't you? So it's nice to have had some participants. Let me stop share so I can see faces. Right.
Thank you very much.
You're welcome. And yeah, we're happy to communicate. So ask away really by email or whatever, and we can send bits and pieces across if that's helpful for people as well.
That would be. Thank you very much.
Thank you all for coming, and enjoy the rest of the conference. And yeah, bye for now.
Bye.
Thank you.
Bye.
Bye.
Bye.